deviations of the ST segment and the T wave, and understand when they represent ischemia and when they do not. And we'll talk a little bit about QT prolongation and then ST depressions. So this is the QRS complex, QRST complex. And so what we're talking about, right, the QRS complex represents depolarization, okay? And the ST segment represents repolarization, or phase 2 of the action potential in the cell. So that's the ST segment. Here's the T wave. And then the QT interval is from the beginning of the QRS to the end of the T wave. So STT changes, there are a number of them. There's ST elevation due to infarction or early repolarization or pericarditis. There's ST depression as caused by ischemia or left ventricular hypertrophy or hypokalemia. There are T wave changes, both inverted and peaked, and we'll cover all of this material. So it's important to know that in ischemia with ST elevation, considered traditionally to be transmural ischemia, that may not be exactly true, but it's important as a concept. The T wave vector and the ST vector both travel toward the electrode in the region in which the ischemia is taking place. So the first change is a T wave, peaked T wave, as seen here, and the second change is ST elevation, as seen here. And there are different kinds of ST elevations caused by ischemia: convex, upsloping, straight horizontal downsloping, and typical non-ischemic ST elevation is concave. You can think of it as a frowny face or smiley face. So a coved convex down will be ischemic, and convex up, concave up will be non-ischemic. So smiley face as opposed to frowny face. It's a good way of remembering it. So here's a 68-year-old man who came to the emergency room complaining of chest pain. And this is his first ECG. There is sinus rhythm. It's interrupted by premature ventricular beat, premature atrial beat. So you have to sort of look between, so-called, look at the native complexes as opposed to the PVCs. Okay, and so here we can see here in leads V1, but especially 2, 3, and 4, and 5, that there are very tall T waves, tall out of proportion to the QRS complex. You notice, very clear. Okay, so this is a sign of ischemia. This is the first sign of an ST elevation MI, and sure enough, 45 minutes later, there is now ST elevation in V2, 3, 4, and 5. Okay, so the tall T waves precede the ST elevation in STEMI. So this is the evolution of the ECG in ST elevation MI, or STEMI. In the olden days, that is before reperfusion, or in situations where reperfusion is not achieved because of either delay on the patient's part or delay for some other reason, the changes go something like this. All right, here's normal. Here's the what's called hyperacute T wave. Here's ST, then followed by ST elevation, followed by the development of Q waves, and the ST segments begin to come down. The ST segments come back to the baseline. The Q wave continues, and there is now T wave inversion, which recovers, and you're left with a Q wave in that lead. That's what used to happen. But today, at least in the United States, especially in centers that have the capability of performing percutaneous interventions, these patients are intervened upon at this point. And so what you have is reperfusion, which leads to T wave inversion, noticed here. So it goes from here to here as opposed to this way. Now, you can locate the source of the ischemia based on the ECG leads in which the changes occur, and get an idea of the coronary artery which supplies that area. So leads 2, 3, and AVF are the inferior leads. They're more likely to be right coronary than left circumflex, but the circumflex can cause changes in this area. If the ST segment elevation in lead 3 is greater than lead 2, that's 90+% means that it's the right coronary artery. The left anterior descending coronary artery will cause changes in V1, 2, 3, and 4. Okay. The changes in 1 and AVL and V5 and V6 are called lateral. They may be the circumflex or a diagonal branch of the left anterior descending. So you can have left anterior descending disease and have ST elevations in 1 and 2. But if you have only leads 1 and not 1 and 2, 1 and AVL, excuse me. If you have only these changes and laterally, then that's probably not the LAD. It's probably the circumflex. So here's a 71-year-old man who complained of shortness of breath and almost passed out. And here's his electrocardiogram, and it shows P waves at a rate that is different from the QRSs. The atrial rate is different than the ventricular rate. The atrial rate is 300, 150, 100, about 80. And the ventricular rate is 300, 150, 100, 75, 60, 50, 43. So the atrial rate is 80 and the ventricular rate is 43. There is complete heart block. The P's and Q's have no relationship to each other. You'll also notice that there is ST elevation in leads 2 and 3 and AVF. So we're dealing with inferior myocardial infarction, inferior STEMI, and the ST elevation in lead 3 is greater than lead 2, in which case this indicates that the right coronary artery is the one that's involved. And sure enough, a mid-right coronary artery occlusion was stented, and this is the ECG following that. See, the ST segment elevations are gone, and conduction has resumed. So there's now sinus rhythm with 1-to-1 conduction. Why was there third-degree AV block? okay, because of AV nodal ischemia, right? If you recall from last week, the right coronary artery feeds the AV nodal artery in 90% of people. And so this mid-right coronary occlusion led to ischemia of the AV node and third-degree AV block, which recovered. AV block in the presence of inferior myocardial infarction usually recovers, which is different than anterior infarction. Now here is inferior infarction. Here's ST elevation in 2, 3, and AVF, and also V5 and V6. But there are these very deep ST depressions in V1 through V3. This represents ischemia in the posterior portion of the ventricle, and it can be appreciated if you hold up a mirror and look at these changes as mirror images, and it looks like there's ST elevation, doesn't there? So what you see here is that the vector, here's the posterior part of the left ventricle, the vector is traveling toward the back, toward V7, V8, V9, where you'd find ST elevations. And in V1, 2, 3, you see ST depressions. Now, ST elevation is not always acute myocardial infarction. There's a mnemonic for the various causes of ST elevation: electrolytes, left bundle branch block, early repolarization, ventricular hypertrophy, some arrhythmias, Takotsubo disease, infarct and injury, and vasospasm. So here are ECGs showing left bundle branch block. I think we showed this last week, and you'll notice that in leads V1, 2, and 3, there is ST elevation. Not so obvious in this tracing, which is consistent with left ventricular hypertrophy. And this leads us to the concept of secondary ST and T wave changes, repolarization changes in the presence of abnormal depolarization. And so what you look for to show that the expected secondary changes are that the STT changes are in a direction opposite of the major QRS abnormality. So here we have two examples of left bundle and LVH, where the major QRS deflection is down. Therefore, one expects that the ST segment and T wave will be up, as they are here. In lead 1 and V6, the major deflection is up. Therefore, ST segment and T wave are down, as seen here and here. With typical right bundle, with RSR prime, the R prime is the major deflection, major abnormal deflection. It's upright, and ST segment and T wave should be down. And the opposite would be true in lead V6. Now, here's a 67-year-old woman who complained of chest pain at rest. This is a historic ECG, right? It was taken in 1991. So the director of the electrocardiographic laboratory at Beth Israel Beth Israel Hospital at the time gave this to me because it was so unusual. You'll notice that at 7:47 in the morning, she has these very nasty looking ST elevations in the inferior leads and in the lateral leads with reciprocal changes. We're going to talk about that in leads 1 and AVL. Okay, so should we call the cath lab for this patient? Should we send this patient directly to the cath lab? Somebody want to put the answer in the chat? Message, okay. Well, here we have, no, we shouldn't call the cath lab, and perhaps a cabbage would be better. Well, before you rush off to that, we'll give the patient a nitroglycerin. And this is what happened. This is 6 minutes later. All the ST changes are gone. Okay, this is an example of coronary vasospasm, or what's called Prinzmetal angina, as described by Myron Prinzmetal, cardiologist in the United States. And here I'll show you here. This is a good illustration. This is generalized coronary vasospasm. This is during catheterization, generalized vasospasm, and relieved by nitroglycerin, as you see here. This is also to illustrate that with the development of vasospasm, so this is actually an example of vasospasm that occurs here. The ST segment is normal, then it starts to elevates more as we're watching it, and then ventricular tachycardia. So it's not always a benign condition. Well, it's not really a benign condition to begin with, but it can be quite dangerous. Now, here is a 36-year-old man who has hypertension, hyperlipidemia, and he's had 3 hours of chest pain, which is worse when he lies down. He has ST elevations in leads 1, 2, I'm not sure there's one in there, L, AVL, possibly AVF, V2, 3, 4, 5. What is this? Is this ischemia? Aha. Good for you. Good for you, Abdul Rahman. Got it. This is pericarditis. So there is diffuse ST elevation, which he recognized, and there's also PR depression in lead 2 and PR elevation in lead AVR. Okay, again, seen here. Okay, here's a 47-year-old woman who complained of sharp pinching chest pain to one of the nurse practitioners in our clinic. The nurse practitioner came over to show this to me because it says consider acute ST elevation MI. Okay, is this an ST elevation MI? Should we put her in an ambulance and send her to the emergency room? or should we not? The answer is we should not. This is the early repolarization abnormality, ST elevation from the J point, okay, with a notch. It's called a J wave, and here it is. It's showing those a little more prominently, and actually I can enlarge this, and you can see that J wave right there. Okay. In addition to which, this is a smiley face. The ST segments are smiley face, not frowny face. They're concave up, so that is not an acute ST elevation MI. This is the early repolarization abnormality. We did not send her to the emergency room. Just of note, if you exercise a patient with early repolarization, it improves. Okay, so here we have some very tall T waves noticed here. Okay, are these hyperacute T waves associated with early ST elevation MI, or are these hyperkalemic? What do you think? Hyperkalemia, says someone. Anybody else? Early STMI, says someone. And okay, that is in fact the dilemma. And here's how you can tell the difference. Hyperkalemic T waves are very pointy. So pointy they can prick your wrist, your finger. Think of it, think of it that way, with this illustration. Whereas hyperacute ischemia, the ST segments, the T waves will be symmetric, they'll be broad-based, they're not pointed, and the QT interval tends to be prolonged. And again, the T waves are out of proportion to the QRS complexes. Okay, here's a woman in her 40s who was brought to the emergency room after she was found down and has this ECG. There's not a lot of question about the origin of these pointed T waves. Her potassium was 8.1. And this is after it was lowered, after calcium gluconate, insulin, and bicarbonate. Her potassium was lowered to 6.5, and they're still there, but they're much better. This is severe hyperkalemia, and there are a number of changes with severe hyperkalemia. QRS is prolonged. It's bizarre. Here are the pointed T waves. And they're really pointy, as noted here, and you cannot see this. In fact, it's sinus rhythm, but you can't see the B waves. So a computer will call this a junctional rhythm, but it's not really a junctional rhythm. Okay, now here is a 54-year-old woman who has hypertension and who has been abusing alcohol who presented to the emergency room with 3 episodes of syncope in the past 24 hours. Here's her ECG. It's got sinus rhythm. This is a ventricular couplet. What else do you notice about this? And that might help us to diagnose the cause of her syncope. What do you notice? Well, you got the arrhythmia right. But what is it about this? There you go. Yeah, Abdel Rahman got it. The QT interval is markedly prolonged. Goes from here to all the way over here. Right, and the normal QT is less than half of the RR interval. Long QT is more than half of the RR interval, as you see here. And sure enough, polymorphic VT, as you suspected, which happened to deteriorate. She was successfully resuscitated, and her potassium turned out to be 1.9, which was the source of the problem. This is an illustration of a typical torsade de pointe. Torsade de pointe is French for torsion of the points. They go from up to down to back up again in the same lead. These are some of the risk factors for drug-induced torsade de pointe, which is one of the reasons I emphasize this, is that there are a number of drugs. I'll show you a few of them on the next slide that are associated with prolonged QT and have the risk of torsade. Pardon me. Torsade de pointe. A prolonged QT interval greater than 500 milliseconds. The use of QT prolonging drugs, especially more than one at the same time. What I call the 3 hypos: hypokalemia, hypomagnesemia, hypocalcemia, diuretics because they cause hypokalemia, hypomagnesemia, heart disease, and bradycardia of any cause. And this is a short version of the list of drugs that pose a risk of torsade. The actual list is a page and a half, single-spaced. So there are many drugs, but the common ones which are involved are antiarrhythmic drugs like sotalol and dofetilide, antibiotics like levofloxacin and azithromycin, and the antifungals, antidepressants and antipsychotics, and then some other ones, including tyrosine kinase inhibitors, one of the chemotherapy agents, methadone, hydroxychloroquine, and ondansetron. And clinical scenarios for torsade, for the risk of torsade, are things like concomitant therapy with 2 QT prolonging drugs, or concomitant therapy with potassium wasting diuretic agent, or something that blocks the metabolism of a QT prolonging drug, renal failure and liver failure. Okay, so now we move on to ST depression. The common causes of ST depression are ischemia, what's called strain, digitalis effect, hypokalemia, hypomagnesemia, and some rate-related changes. So And in the case of ischemia, which is not transmural, considered to be subendocardial, the vector is traveling away from the electrode, hence ST depression. T-wave vector, same thing. Now, one of the causes, a common cause of ST depressions are reciprocal ST changes in STEMI and ST elevation MI. So if you have ST elevation in 1 and ABL, reciprocal changes would be ST depression in 2, 3, and ABF. Likewise, if you have ST elevation in 2, 3, and ABF, you have the reciprocal changes would be ST depression in leads 1 and ABL. Now, here's a patient, a 72-year-old man who was brought to the emergency room. He was awakened from sleep by severe chest pain radiating into his left shoulder. And here's this electrocardiogram. You know, what does this show? Well, a couple of the things that are most striking are ST depression in leads V2 and V3. Okay. Possibly an AVL, not clear. Do you see any ST elevations here? Hard to tell, isn't it? But they're there. You see, here's ST depression in AVL and a little bit of ST elevation in 3 and AVF. My point here is that the ST depressions may be more prominent than the ST elevations, but the problem is the ST elevations in the inferior leads, in this case in the inferior leads, and coronary angiography showed a 99% left circumflex stenosis causing them. Now, we've talked about ST elevation MI, and there's a whole group of patients who have non-ST elevation MIs, basically ST depression, and followed by T-wave inversion. So here's a patient. Here's a 77-year-old man who was in the hospital, was on surgical service for a carotid endarterectomy. Post-operatively, he developed extremely hypertension, and this was a hypertensive crisis because he also had chest pain. Here's his electrocardiogram. Okay, now you see ST depressions in leads 2, 3, and ABF, and V5 and V6. But you recall we said that you could have secondary changes, right? So you could have ST depressions where the major deflection of the QRS is upright, and you could have ST elevations where the major QRS deflection is down. So it's not so clear from this ECG until you look at the preoperative tracing, which didn't have that. It had these changes, which are probably due to left ventricular hypertrophy, and it leads 2, 3, and AVF 6, okay, and no real ST elevation. And so I put these together. This is with chest pain. This is preoperatively, and you can clearly see the difference. Here's V4, 5, 6 compared to preoperatively. Okay, and you can see the difference. The troponin level rose and fell, and coronary angiography showed non-obstructive coronary disease. So this was a non-ST elevation MR. Here's a woman, here's a 66-year-old woman with hypertension, diabetes who complained of chest pain. And she has widespread ST depression, 1, 2, 3, AVF, and V3 through V6, possibly, a suggestion in V2, V3 through V6. But she also has ST elevation in lead AVR. Beware ST elevation in lead AVR. It's coexistent with multi-level, when it is coexistent with multi-level ST depression, multi-lead ST depression, rather, it indicates subendocardial ischemia due to a supply-demand mismatch, and the clinical causes are left main coronary artery severe stenosis, or proximal LAD disease, or severe triple vessel disease. So patients with left main coronary artery occlusion generally don't make it to the hospital. So severe stenosis is really what this is. That's what you should think of when you see ST elevation in lead AVR. Okay. It's a useful predictor of poor outcome and the need for CABG, and therefore you should withhold, if you see this, you should withhold clopidogrel because the patient might need to go to urgent surgery. Okay. On the other hand, the absence of ST elevation in lead AVR excludes severe left main coronary stenosis. Now, here are ST segment changes during exercise. They're ST depressions. So here's normal, and then here's abnormal, slow upsloping, horizontal, but especially horizontal and downsloping that persists into recovery of a stress test. So this is a positive stress test indicating ischemia during the stress test manifested as ST depression. Whoops. Oh, okay. Here is hypokalemia with diffuse STT changes, as you can see here, and prolonged QT. And as if you look down here, this is the sequence, right? You get these minor changes, and then you get flat T waves and a prominent U wave, then you get ST depressions, and then a prolonged QT. And here's a patient with hypokalemia and prolonged QTC. As you can see here, the QT is very long. Okay. Here's a 65-year-old man who has atrial fibrillation, for which he takes digoxin. And what you notice is a slow, regular rhythm at 50 beats per minute, no P waves, so this is atrial fibrillation. You can see this sort of thing with a beta blocker and no digoxin, but if the patient is on digoxin, this is a dig-toxic rhythm. These scoopy-looking ST depressions, I say that this is the pill of digitalis. These scoopy-looking ST are typical of digoxin. So this person needs a digoxin blood level, repletion of potassium, magnesium, possibly fluids, and withdrawal of digoxin. All right, the ST depressions are similar to Salvador Dali's mustache, as noted here. Okay, and so finally, we have Van Gogh's yellow vision. Vincent van Gogh, the 19th century artist, painted this picture of himself looking very yellow. Was that holding a foxglove plant? This is the foxglove plant. from which digitalis comes, digitalis and digoxin. So the story is that the digitalis in those days was used for the treatment of depression, which of course didn't help, but made him digitoxic. And yellow vision is one of the extreme side effects of digitalis toxicity. This is his famous Starry Night. Again, very yellow, very yellow. Very.
We'll be happy to relay your questions to Dr. Shulman.
Yes. Will there be more lectures? Yes. Well, lecture, number 3 in the series is, when is it, Ahmed? Next week?
So we're going to skip next week.
Yeah, go ahead.
And then we have one, I'll tell you the exact dates. We have one the following Saturday in December.
The first Saturday in December. Okay, hang on.
Right.
Let me.
So it'll be December 7th, the next lecture.
Okay, let me look at my calendar.
Is it December 7 or 8? I have to check. Yeah, December 7. I was right. Yeah, so the next one will be December 7th.
December 7th.
Yeah. Yeah, so, and once we're done with these lectures, Dr. Shulman, we can talk offline and see if you'd like to give another series. So we can take that offline.
Okay, yeah, sure. We can talk about that, Ahmed.
Okay. Sounds good. Well, thank you so much. Thank you so much for your time. Thanks to all our participants.
Okay.
Thank you.
Thank you, everybody. Have a good weekend.
You too. Take care. Thank you. إن شاء الله بإذن الله عز وجل ننزل لكم التسجيل إن شاء الله على قناة التليجرام بإذن الله عز وجل، وبرضو على الواتساب ننزل لكم إن شاء الله التسجيل. لو في عندكم أي أسئلة أو مقترحات إن شاء الله زي ما قلت لكم المرة اللي فاتت، الهدف إن شاء الله أننا نستقطب دكاترة يعني تانيين من مجالات أخرى في الطب. نفع الله بنا وبكم. ما تترددوش يعني تتواصلوا معنا في أي لحظة وأي وقت، ويا ريت تنشروا الإعلان دوت في يعني في جروباتكم اللي انتوا فيها، يعني جروبات الطب والحاجات دي انشروها يعني. جزاكم الله خير حتى إن شاء الله يعم الخير على الجميع. جزاكم الله خير. سبحانك اللهم وبحمدك نشهد أن لا إله إلا أنت نستغفرك ونتوب إليك. السلام عليكم ورحمة الله وبركاته.